So I'm Rob Story. I'm Professor of Cardiology at the University of Sheffield in the UK, consultant cardiologist in Sheffield. Here are my disclosures. These are available on the ESC website as well. This symposium is sponsored by Accumetrics, who make the Verify Now device. So we know a lot about platelet function now and about how the different antiplatelet drugs work. We know that aspirin is a very effective inhibitor of COX-1, blocking thromboxane A2 release. But that plays a limited role in platelet reactivity. And so in high-risk settings such as PCI, we need to go further. And that's where P2Y12 has proven such a major role, because it amplifies all the platelet responses, amplifies platelet activation, and all the key things that contribute to platelet-mediated thrombosis. And we've got a number of agents now that target this receptor. And we know well that clopidogrel, it's a great drug. It's been the mainstay of treatment in PCI and ACS for many years. But there's a variable response with good responders down here and non-responders up here and range in the middle, and this patient coming back twice blocking off their stent despite a good angiographic result. And this relates to primarily to the metabolism of clopidogrel, a prodrug converted to its active metabolite, and relying on these liver CYP enzymes to get to its active form and being rapidly inactivated by other pathways. And this is very variable between individuals. And lots of factors affect the response to clopidogrel. Some of the key factors listed here, including genetic ones. And it's complex, and so how you can predict the response to clopidogrel, even if you know the genetic data, is far from clear. And so pharmacodynamic monitoring is really the key to assessing the response. But there's been debate to date as to whether we've got the right systems for doing that. Many studies now in this position paper led by Bonello et al. Showing a range of different studies that have identified particular cutoffs in platelet reactivity tests that predict key ischemic endpoints and stent thrombosis, from light transmittance aggregometry to the VASP assay to the Verify Now P2Y12 assay to the multiplate analyzer. All these tests which can assess P2Y12 blockade can predict prognosis in these ischemic syndromes. Now, although clopidogrel's been a good drug, there's increasing awareness of some major limitations, that, as I say, this variability in response, part of which is genetic, leading the FDA to issue a black box warning about this issue, saying be aware of it. But at the same time, in this response from the ACCF, saying, well, we don't really know what to do with this information yet. And the evidence base is not sufficient, when this was published, 2010, to recommend routine genetic or platelet function testing. Here was the 2011 focused update of the American guidelines. And here includes this sentence saying platelet function testing to determine the platelet inhibitory response in patients on phenylpyridine therapy may be considered if the results of testing may alter management. Now, obviously, that's a bit vague, but it opens the door to clinicians to make up their own mind when the right circumstance may be to assess the response to clopidogrel. And similar statement for genotyping for loss of function variants in CYP2C19, of which STAR2 allele is the most common, but there are others. The ESC guidelines released over the weekend also include various guidance on P2Y12 inhibitors, and with specific reference to platelet function testing, say that this may be considered in selected cases when clopidogrel is used, recognizing this variability in response and the potential functional implications of that. Now we've got new drugs which can circumvent at least to some extent, the variability in response to clopidogrel. We've got prasugrel with a more efficient metabolism here. Active metabolite, very similar to the active metabolite of clopidogrel, you get more of it. And for an example here, the data from Triton showing how stent thrombosis is profoundly reduced with prasugrel compared to clopidogrel, albeit not abolished. Proof of concept that more effective P2Y12 blockade is more effective at preventing stent thrombosis, as had been predicted from many of these observational studies. So this was widely anticipated as a result. The downside being the increase in bleeding and increase in life-threatening and increase in fatal bleeding. And so this raises challenges in terms of using thienopyridines as to whether you need to operate within a therapeutic window, or more particularly, look at your individual, what their ischemic risk is, what their bleeding risk is, and decide where you want to be in terms of the level of P2Y12 inhibition. The SWAP study looked at pharmacodynamic responses in those patients who are on clopidogrel and then either continued on clopidogrel maintenance dose or switched to a prasugrel maintenance dose, or given a 60 milligram loading dose of prasugrel and then followed by a maintenance dose. You can see here that the maintenance dose of both clopidogrel and prasugrel doesn't have an immediate effect apart from a slight increase in inhibition post-dose, but the prasugrel maintenance dose here only achieving significance at the 7-day time point, whereas it took a loading dose of prasugrel to effectively suppress the platelet reactivity. Now here's a case, one of my patients, 64-year-old lady, diet-controlled type 2 diabetes mellitus, average weight for a diabetic, previous history of PCI to the LAD 11 months previously, now admitted with chest pain, troponin rise indicating a non-ST elevation myocardial infarction. And this is the angiogram. You can see the outline of the stent here with very severe in-stent restenosis and a segment of disease beyond that, compromising the flow in the LAD. Now there's a bit of debate about restenosis leading to reinfarction. That's clearly now an association, but the contribution of coronary thrombosis is slightly in doubt. But we've generated preclinical data suggesting that there may well be a continuum between subclinical stent thrombosis and restenosis, because thrombosis can drive inflammatory response in the vessel wall. So this is sort of interesting whether the clopidogrel response was relevant in this restenotic response, as well as the infarction that occurred subsequent to that. And so that was treated with drug-eluting stenting covering the in-stent segment and the segment beyond, with excellent angiographic result to the LAD, a little bit of compromise to this diagonal branch here, and always a concern that when the anticoagulant wears off, you may lose these side branches and get a periprocedural infarction. So in view of those concerns, the previous history, side branch involvement, diabetic patient, we did some platelet function testing. The Verify Now P2Y12 response 280, indicating a poor response to clopidogrel, confirmed also by the multiplate assay. And so consequently we gave a prasugrel loading dose, empirically using a reduced loading dose of prasugrel, since although we've got pharmacodynamic data on the 60 milligram dose, we don't have safety data, so we're acting in a sort of grey zone here in terms of evidence-based practice. We know P2Y12 inhibition will influence this patient's risk, but we don't know the safety and efficacy of strategies for responding to that. So this is my sort of empirical strategy for this patient. Now, since this strategy that we devised with switching from clopidogrel to prasugrel in selected cases, we've now got ticagrelor available in the UK. It's available in other EU countries and also in the US and Canada, and 43 countries around the world now. And this is a reversibly binding agent, doesn't need conversion to active metabolite. It's got a more rapid onset of action, just like prasugrel, compared to high loading dose of clopidogrel. But in addition, it's got a more rapid offset of effect when you stop the drug, so potentially an advantage in patients who need to go for coronary artery bypass surgery or other major surgery. And in the platelet function sub-study, using the Verify Now device, these were patients who'd had at least a month of treatment, and we looked at the platelet reactivity before the next maintenance dose and then 2 to 4 hours afterwards. So before is the trough and 2 to 4 hours after dosing is the peak. And you can see with clopidogrel, both before and after dose, this wide range of response. Some good responders, about 30% having a good response to clopidogrel, but a good proportion above this threshold, which is one of the thresholds identified as predicting risk of stent thrombosis and other ischemic events, and some patients well above it. So whilst with ticagrelor there's one patient above that pre-dose, but then post-dose every patient is well suppressed on this assay. Linking with this platelet function data, not clear whether that entirely explains these results, but ticagrelor progressively reducing the risk of both myocardial infarction and cardiovascular death over the course of 12 months compared to clopidogrel. And when we looked at nearly 10,000 patients in a genetic sub-study, we saw an early effect of this genetic defect that impairs the metabolic activation of clopidogrel, but no later effect beyond about 30 days or so, where the curves are even converging. And so by 12 months, the conclusion being that ticagrelor was superior to clopidogrel, independent of genotype that influences clopidogrel metabolization. And ticagrelor, again as anticipated for a more effective P2Y12 inhibitor, effectively reducing the risk of stent thrombosis. Now, total major bleeding not different between the two groups, but this included surgical and non-surgical bleeding. If you divide it up into those two, then non-CABG bleeding was increased as expected with ticagrelor, but no difference in the CABG-related bleeding. In fact, a numerical trend towards less with the ticagrelor. And so that's why overall there was no difference in the bleeding. There is a dose-dependent incidence of dyspnea with ticagrelor. This was a phase 2 study showing that this higher dose gave you more dyspnea. Dyspnea is very common for lots of different reasons, which is why you see it with clopidogrel. It's not, we don't believe that to be anything to do with the drug. It's just patients with acute coronary syndrome get breathless for lots of different causes. So the excess here with ticagrelor is drug-related dyspnea. Tends to be mild to moderate, generally well tolerated, but occasionally patients need to discontinue as a result, in which case they maybe need to be switched to thienopyridine. Now, one thing that we did do, we had a small amount of data in patients from a single center following randomization, clopidogrel naive patients, and this is one snapshot of this data. This is the Verify Now responses before clopidogrel or ticagrelor, and this is 4 hours afterwards. We can see in these ACS patients a range of responses before. Most of the ticagrelor patients well inhibited from about 1 hour onwards. Here, this is a 4-hour data, but one patient showing delayed absorption, a STEMI patient. And this has been observed also with prasugrel and clopidogrel. The P2Y12 inhibitors may not be well absorbed in the early stage of an acute coronary syndrome, and so a functional test may help you to decide whether the drug has been effectively absorbed. So to conclude, individuals with poor PD response to clopidogrel at increased risk of ischemic events, particularly stent thrombosis. This is partly genetic, partly other causes. Prasugrel's got this superior PD profile translating into improved clinical outcomes at the cost of increased risk of major bleeding. Ticagrelor, similarly, a superior PD profile in terms of onset and mean level of inhibition, but also faster offset. Again, achieving superior clinical outcomes compared to clopidogrel, and particularly reduced mortality regardless of genotype, but with minor bleeding and dyspnea occurring as side effects in dose-dependent fashion. And so platelet function testing offers us a means of optimizing and individualizing P2Y12 inhibition, as well as checking on absorption in the acute setting, and the selective use of this is supported by the guidelines.